Good morning, everybody. Thank you for joining us today. We'll likely have a few more people filtering in, but we might go ahead since it's just ticked over to 10 a.m. So hi, everybody. My name is Kim Cowan. I am a project coordinator here with SERSH, which is the Centre for Excellence in Rural Sexual Health, for anyone not familiar. I work out of Shepparton and Parkville, and we also have team members at Bendigo. And it's my pleasure to welcome you here to the SERSH Sexual Wellness PD webinar for October 2025. We host these PD webinars every month on a range of different sexual health topics, sometimes with a clinical focus, education, community, research, all sorts of different topics. If you're interested, many of our previous webinars are available on our website or on YouTube if you search for SERSH SWPD, and they're all well worth a look. And then just watch this space for sessions that we have coming up. There is one more in 2025 in November, and then we'll be back on in February 2026. Before I go any further, I would like to offer an acknowledgement of country on behalf of the University of Melbourne and SERSH. We would like to acknowledge the traditional owners of the lands on which we live, learn and work. Wherever we are zooming in from around Victoria and Australia today, we are on Aboriginal land, and we would like to pay our respects to elders, past and present, and extend that respect to any First Nations colleagues who might be joining us today. Before I introduce our speaker, just a couple of little housekeeping things. Our session today will be around 60 minutes long, and we should have time for some questions at the end. So if you think of anything throughout the session, just pop it in the chat and we'll save questions for the end. And we're also recording this session, so you'll have the opportunity to rewatch it or share it with friends or colleagues who weren't able to join us today. But without any further ado, it's my pleasure to introduce our speaker for today, Dr. Steph Munari. Steph is a public health physician and is undertaking a PhD at the Burnet Institute and the University of Melbourne. Her PhD aims to strengthen the management of chlamydia in primary care. And Steph has kindly agreed to speak with us today about young people and STIs, including preferences and motivations for partner notification from the 2024 Sex, Drugs and Rock and Roll Survey. Welcome, Steph. Thank you so much for joining us today.
Thank you. Thanks, Kim, and hi, everyone. As Kim has mentioned, I'm trained my background's more medical, and then I've specialised in public health medicine. So I'm not a sexual health physician treating patients one-on-one, but I take more of that kind of public health, population health approach, and that's kind of more the slant of my presentation today. And then I'm also doing a PhD just at the end, both at Melbourne Uni in the sexual health unit with Jane Hocking, and also at Burnet Institute as well is my PhD looking at chlamydia. So hence today's chlamydia obviously affecting subset young people and partner notification being really important. So that's why the topic today. So I'll share my screen. So can you see the presentation mode of the?
Yeah, that's great.
Okay, great. Okay. I've just got to find my presenter slide. Okay, there we go. Okay. So I'd also like to acknowledge, so the Burnet Institute is located on the traditional lands of the Boon Wurrung people. So to acknowledge them as the traditional owners, but also I work at Melbourne Uni and at home in Greensborough, which is also on the land of the Wurundjeri people. So acknowledge them, pay my respects to elders past and present. So as an overview, I'll talk a bit about young people and STIs, then more about STI controls, so about prevention and management. Then the second half of the presentation will be on one of my PhD projects, looking at young people and how they feel about partner notification. I'll hopefully only speak for about 30 minutes so that we have time for questions and discussions afterwards. And so hopefully after the presentation, you'll have a better understanding of STIs in young people. I acknowledge many people here already probably have a really good knowledge base about particularly STIs, but including common ones among young people, rates and risk factors, general principles of STI prevention and control, and what partner notification is, why it's important, how we can do it and where we can find further information and resources. And with that project of mine, a little bit more insight from a subset of young people who participated in a survey about how they feel about partner notification. So I wanted to start with some definitions because young people term is thrown around a bit and can seem a bit vague or broad, but generally we're talking about 15 to 29-year-old people. I'm using that definition because that's what's used in the Australian STI management guidelines for use in primary care. But just out of interest, the Australian Bureau of Statistics and the United Nations use 15 to 24, and the AIHW, Australian Institute of Health and Welfare, use 12 to 24. And the STIs, the partner notification applies really to all STIs. Particularly, I've sort of listed a lot on screen, but I'll mostly be referring to chlamydia, gonorrhea, and syphilis being the most common among young people. And also to distinguish contact tracing from partner notification, because they're sometimes used interchangeably. Contact tracing generally refers to is more of a broader umbrella term just for any kind of infectious diseases. We probably heard a lot about that in COVID, but it's usually led by public health authorities, whereas partner notification is a bit more specific to sexual health and STIs, and it's usually patient initiated. So onto young people and STIs. So chlamydia, gonorrhea, and syphilis are the most common STIs among young people. So this is notification data from the National Notifiable Disease Surveillance System, showing notifications on the y-axis from 1991 to 2025. And you can see that it's mostly within those roughly kind of the 15 to 29 or 15 to kind of 30 groups, where each of the three STIs are kind of have the highest number of notifications. Syphilis, infectious syphilis is of a particular concern among young people of reproductive age due to that risk of congenital syphilis, which is where a pregnant person who has a syphilis infection can then, that condition and infection can be passed on to an unborn child and causing a disease called congenital syphilis there. Very preventable, very treatable, and unfortunately we're seeing higher rates of congenital syphilis as well. So why are STIs higher among young people? I've tried to break them into the sort of ecological model where we think about it at the biological level. Lots of STIs are asymptomatic. We know that about 70% of women with a chlamydia infection won't have any symptoms, about 50% of men. So a person might not even know that they've got an infection and they're going about their daily life and unintentionally transmitting the STI. Also, younger women or people with a cervix tend to, so that they have a cervical ectropion, which is where the cervix, the cervical os, the middle of the cervix, has a more sort of outward a layer, a more exposed layer of this cervical ectropion, which is a different type of cells that can make it easier for chlamydia and gonorrhea bacteria to establish an infection. At the behavioural level, younger people tend to have a higher frequency of partner change and less consistent condom use. And then at that broader structural societal level, lots of factors, but a few on the screen, things about insufficient sexual health education and knowledge and skills. There might be perceived irrelevance and other barriers like embarrassment, stigma, and then access barriers to accessing and paying for testing and treatment. I also wanted to mention that young people are listed as a priority population in the latest 5th National STI strategy from the Department of Health, Federal Department of Health. I won't go into sort of the details on screen, but they've listed things we've talked about, like the structural barriers to accessing healthcare and some other key considerations for young people as to why they're a priority. And you can see at the top of the screen, they've defined young people as 15 to 24, which is that United Nations definition. So onto STI control. So I'm going to talk about prevention and management as part of this. So to start with prevention, I like to think about the primary, secondary, tertiary prevention framework when thinking about this. So for primary prevention, we're talking about preventing the infection before it even occurs. So things like abstinence is listed in there brackets because we know that's not a very effective intervention to prevent STIs. Vaccination, we only have vaccines for, in terms of STIs, Mpox, human papillomavirus, and Hep B virus. But of course, there are a lot of different vaccines in the sort of pipeline that are being created. But that's potentially an option there in future as well. Pre-exposure prophylaxis, and then barrier interventions like behavioral interventions like barrier contraception, reducing number of sexual partners, maybe having conversations and improving consent and communication skills to talk to partners before sex about being tested and treated, and helping to reduce stigma. At secondary prevention is about if this person does have an STI, detecting that early, treating them early, and preventing further complications or sequelae. So vaccines have a role there, but things like asymptomatic and antenatal screening, post-exposure prophylaxis, making sure people are tested early, treated early, retesting so they're not getting a reinfection, and partner management falls into this category. And at the tertiary level, this is about making sure someone doesn't, or reducing the risk of them developing further complications. So things like pelvic inflammatory disease, which can be due to a few different STI infections. So things like making sure that's PIDs early, identified promptly, treated, things like antiretroviral therapy for HIV, and making sure people are linked to care, provided psychological support, and preventing reinfections, which can make complications worse down the track. So that was prevention. So and then when we look at management, I will sort of discuss this as more the case contact community kind of framework. So to start with cases, of course, important is the antimicrobials prescription, so right dose and duration, and correct antimicrobial stewardship, but also making sure that we look for other STIs. Sometimes they can come together, and complications that might be present. Organising a retest for instance, for chlamydia, that's 3 months down the track. A retest is recommended. That can be booked at the time of, at the time of diagnosis, and providing advice to the case or the person that has the STI by providing an information sheet, and this could be an SMS link to an info sheet or printed, and the advice is about making sure they complete the course of antibiotics. They might need to avoid sex for 7 days or until they've finished the antibiotics and no symptoms, avoiding sexual contact for a certain time period depending on the STI, helping them to notify their partners, and just as part of this is disease notification, just to contribute to that overall surveillance. Then when we think about contacts, so contacts of someone with an STI, this is where really partner notification is really important, so that they can know that they need to get, that they might have been exposed, they can should get tested and treated if they need it. We can also provide information for the partners, specifically and only for chlamydia. There's patient-delivered partner therapy, which is where the case or patient in front of you gets prescribed their antibiotics for chlamydia, but we also can give them a prescription to the case that they can give to their partner for some azithromycin to treat the partner as well. Then post-exposure prophylaxis can also fall here, and then we can think about pre-exposure prophylaxis for future encounters. This is a little bit more information from the Victorian Department of Health website on patient-delivered partner therapy. So that's just for chlamydia, and they've got a nice pathway and flow chart for that detailed eligibility criteria, what needs to be documented in the patient notes, and there's also a prescription template as well on the website. And so a little bit more just to unpack about partner notification. So there's sort of 4 main aims of partner notification. So this is to reduce transmission, so further spread, reduce reinfection in the case patient, ensure early testing and treatment of partners, and to reduce complications for both the case and partners if they have the infection. So it's the responsibility of the diagnosing clinician to initiate the contact tracing. And there are 3 different ways that contact tracing can be performed. So in patient initiated, that's when the patient is supported to perform the notifying. The provider can do it on the patient's behalf in provider initiated, or in sort of more complex situations, it can be referred to a specialist contact tracing support like a public health unit. Complex situations might involve things like HIV or syphilis in pregnancy, or where there's domestic violence or sexual assault concerns, outbreak settings, or child safety or language issues. Because it's sort of reserved more for those complex issues, because public health units don't routinely trace all notifiable conditions as for resource limitations. That trace back period as to when the patient will need to trace back for how many months or a time frame as to identify partners within depends on the STI. For chlamydia, that's 6 months. And the message that should be given to the partner is that they may have been exposed. It's best that they get tested so they can be treated if they need it. So if we're supporting a patient to perform their own partner notification, there's sort of 4 kind of steps, and this is from the Australian STI Management Guidelines website. So you can introduce the reasons as to why we need to do the contact tracing, which we've mentioned above, the asymptomatic nature, helps them to get tested and treated, avoid sort of complications down the track, and prevent transmission. We can help the patient by identifying the traceback period, and then talking to them about, with non-judgmental language, about different types of sexual contact and behaviours like injecting drug use that might qualify as needing to be identifying that partner to be notified. And then we can talk to them about all the different sort of methods that we can that they can perform the notification through. So I've kind of put them in direct or anonymous. So direct as if they're happy to be, for their partner to know that it's them notifying them. So, face-to-face conversations, text message, phone call, helping them with advice on maybe the setting and how to do it, what to say, with like the template example shown on screen, and providing an info sheet for where they can go, and even like advice on testing sites that they can attend locally. And then anonymous methods are the websites. There are a few different websites which you might already know about, like Let Them Know, Drama Down Under, and Better to Know. And I'll go through them in a sec. And then, of course, documenting in the patient notes about the discussion. So I've got listed on this screen some useful resources. I had them more there for your reference later, but I just wanted to show, hopefully this works. Can you see the my internet screen now? Yeah, okay. Just these, I'll just go through. I'm much more of a visual person, so I wanted to sort of show you those sites that I had listed on the screen. So you might hopefully already be familiar with the Australian STI Management Guidelines for use in primary care. I've used these so many times to look. You can look at by STIs and go and have a look at, and it's got a really nice layout of how to diagnose, and how to manage, doses and that sort of things. And there's bits on contact tracing, and it tells you the trace back time, etc. They also have information on contact tracing that you can go through there as well. There are also the ASHM, Australian Society of Sexual Health and HIV Medicine, ASHM contact tracing guidelines, which are an excellent resource. This one, that this page I just clicked on with how far back to trace. So it's got all the time periods here, and just lots of information on ways to notify and more resources. And some of these here, so Let Them Know website, this is what this looks like, and there's tips and videos on how to tell people. There's an SMS. You just need a name and a mobile, and you can tick the type of STI that you'd be notifying, and then it sends them a anonymous text message. Drama Down Under is another website that can be used, and this is the Better to Know website that's I mean, anyone can use, but a bit more tailored towards Aboriginal Torres Strait Islander people. And this one I just noticed recently, when you go into the Notify a Partner, Create a Message tab, you can actually choose by the type of relationship. And I sort of went through them all. I can show you what casual hookup looks like, and you can select the STI. You can leave the name blank or enter it, and then it actually shows you what the message is going to look like. And so the casual one, so it's just, hey, just a heads up, you might have been exposed to chlamydia, a good idea to get tested. You can find more info here, take care, was more of a sort of like casual kind of way, of a bit more conversational way. You know, the hey, just a heads up had a bit of a different tone to the in a relationship message. But I thought that was quite interesting and relevant to the project I've just worked on. So they were the main ones I just wanted to show you. I'll go back to the presentation. So I've got all those links there for future reference as well. And just coming back to then that management framework at the broader level, the community level, that's more about the sexual health promotion, reducing structural barriers to accessing treatment and care, reducing stigma, increasing consent and conversation skills among young people in general. And then at that broader level is surveillance and disease notification. So we have a good idea of the rates of STIs, but also how effective public health interventions are at trying to reduce them. So onto the second half of the presentation, which is one of my PhD projects, looking at a survey among young people. So the reason why I wanted to do this project as part of the PhD is a few reasons I've mentioned already about STIs being highest among young people, and that we know that partner notification is really important in that overall management. But we know that they vary, and we know that patients and providers experience barriers to engaging in partner notification. Patients can be worried about retaliation from partners, loss of relationships, embarrassment, stigma, and providers. Some feel they lack confidence or are concerned about confidentiality, or concerned about creating a negative impact on their patient-provider relationship. There's few resources available that are more tailored by communication method and partner type. So we wanted to understand young people's preferences and motivations for partner notification, including their preferred methods for notifying and being notified by sexual partners. So the data for this project came from last year's Sex, Drugs and Rock and Roll survey. This is an online cross-sectional survey that's administered by the Burnet Institute each year. And to be eligible, you need to be aged 15 to 29 and living in Victoria. We recruited online via social media between March and May last year. And the whole survey has 61 questions in total. They're more broadly on sexual health and behaviours, pornography use, alcohol and other drug use, and mental health. And then we built in 12 questions in a module specifically on partner notification. And we collected demographic variables, and we asked survey participants if they'd want to notify or be notified, why and how. And we asked through closed-ended items and also free text. And the free text was analysed using an inductive content analysis and there was ethics approval for the survey from the Alfred Hospital. So we had 1,163 people who completed the survey. The median age was 21.6 years. 60% identified as a woman, 26% as a man, and 13% as other. For gender identity other, they'd included non-binary, gender fluid, gender not listed, and I don't wish to say, or I don't wish to say. And then 40% of survey participants identified as heterosexual, 8% gay, homosexual or lesbian, 70% bisexual, and 35% other. For other sexual identity, that included pansexual, asexual, queer, questioning, don't know, don't label, I don't wish to say, or really any combination of any of these options. So when we asked participants would you notify a sexual partner of an STI risk? So this was all hypothetical. 91% said yes, they would, 1% said no, and 8% said it would depend, or I don't wish to say. I'll go into it depends reasons in the next slide. And when asked, would you want to be notified? An even higher amount, 98% said yes, I'd want to be notified. 1% said no, and the less than 1%, it depends or I don't wish to say. When we asked about motivation, so we said, as an optional next question, if they said yes, I'd want to notify or be notified, can you tell us more information about that? So it was a lot about feeling like it was a responsible thing to do, to look after their health, partner's health, reducing spread, part of informed consent. They have the right to know, lots of different kind of themes there. When asked why they would not want to notify or be notified, it was about fears of getting into trouble, or if the relationships didn't end well, or they were worried about feeling embarrassed, scared, or uncomfortable, or maybe there was a history of sexual assault. And for people that said it would depend, it was things like if they were still in contact, if they were still on good terms, if they could trust the partners with that information, and things like if it could be done anonymously. We then asked the survey participants how they would prefer to notify or be notified. So on the y-axis, they were we listed all the different options for notifying. Anonymous methods, second from the top, included really just any way where the identity of the notifier wasn't known to the person who was being notified. So it was like text or email via one of those anonymous notification websites, through a third person or a health professional, or using like an anonymous social media or dating app account. And then we broke this into sort of regular or casual partners. So if we look at notifying and being notified by regular partners, so this is in the red, or that reddy brown and the purple bars, we see that face-to-face, phone call, and text message were the more preferred options. So this was communicating with regular partners. But then if we look at for casual partner communication, so this is in the yellow and blue bars, we can see that text message was the sort of most preferred option. Then with phone, face-to-face, and anonymous methods were actually also much more preferred for casual partner communication compared to regular partners. The other thing to point out is that social media was also more preferred for casual partner communication compared to regular partners. So to sort of summarize the key findings, we could see from this survey that most people do want to notify and be notified of an STI risk, and they're motivated by a sense of responsibility, and they want to care for their own health, their partner's health, and the broader community. The willingness and way that they communicate does depend on the relationship type, and we saw that for regular partners, face-to-face was probably more preferred over phone call and text, but for casual partners, text message was the more preferred option over phone, face-to-face, and that was fairly equivalent with social media as well. And we also saw that anonymous methods were much more preferred for casual partner communication compared to communicating with regular partners. Just a few study strengths and limitations. We had online recruitment on social media, which was a sort of platform where we know young people are highly engaged. We used hypothetical responses to sort of try and increase our sample size and avoid limiting it to only people who have had an STI, and included free text response to try and add sort of richness and complexity to the quant findings. But we also acknowledged that there were, because it was advertised only in Victoria and it had more women compared to other gender groups, our sample's not representative of all young people in Australia. We used convenience sampling for our recruitment, and as mentioned, the hypothetical scenarios as well might mean that there might be a bit of a disparity between intentions and reality. So someone might say that they would intend to notify, but in reality they might not for various reasons. And we also didn't look specifically at the type of STIs. So that might also influence notification intentions, because some STIs carry different levels of stigma or transmission risk and management pathways. So in terms of implications of the study findings, it's important that partner notification and health promotion messaging empowers and supports that person, the index patient, or the person who's notifying, that it's convenient for them, and that we really emphasize that collective responsibility of looking after their health and their partner's health. We can, in developing or any new resources or tweaking current resources, we can think about tailoring by communication methods and partner types. So this can be things like we saw with the Better to Know website, like changing the tone in different text message templates. We could adapt different face-to-face or phone conversation scripts, things like providing advice on settings, like if there are safety concerns, a phone call or a text or an anonymous method might be a better option for that person and where they're more comfortable, and also making sure we link to information and testing options. This paper was published earlier this year, so I've got the QR code and details there if you'd like to look at further information. And I just wanted to really thank my co-authors on the paper and my PhD supervisors and the participants who shared their time and insights in the survey. I have references listed as well, and then happy to answer or try to answer any questions or have a chat. So thank you.
Thanks, Steph. That's amazing. I actually didn't know that the Better to Know website had an Aboriginal or Torres Strait Islander option there, and or that you could tailor it to the different types of relationships or hookup or whatever. So I love that. It's really useful.
Yeah, I thought that was really useful to know as well. I only just discovered that recently, but yeah, it's really good.
Makes sense. It's really good. Does anyone have any questions for Steph? Maybe something resonated with your own work, or there's a point you might like a bit more detail on? It's nice to see most people do actually want to know and be informed if they've got an STI or they might have been exposed to one. So
yeah, I agree. I think that was really nice finding to come out of it. And it was a lot of like care for their partners and care for their health and wanting to make sure they know as well, and they have the opportunity to get tested and treated if they need it. Yeah.
Exactly. Yeah. What I think you said 91 were willing to notify, but 98 wanted to be notified. So it's only a small discrepancy.
Yeah.
Please pop your hand up or just pop something in the chat if you do have a question for Steph. Brian?
G'day, it's Derm Ryan here from Yakdik. Just testing you can hear me.
All good. Yep.
Great. Thank you. Thanks so much, Steph. That was a fantastic presentation. Really interesting information there. And sort of picking up on the point that was just made about the desire for young people to want to be able to have that conversation or notify a partner. I'm wondering whether there's been any thoughts to having a comparison where we find out whether those motivations are acted on. So have people been diagnosed, and how have they informed a partner within the same study or a different study where we can compare what's happening as a way of maybe further sort of developing programs that work towards a better prevention method and bring those rates down.
Yeah, absolutely. Yeah, and as I mentioned, that's certainly a limitation, is that this survey were hypothetical scenarios. Yeah, it would be really good, and there probably are studies. I think some have looked at. I think one of them I looked at did ask, did you notify? Like, we're asking specifically about their actions. But I think that would be so valuable to understand. And even outcomes, like how did that go? Was there any? Some have looked at retaliation. I know that there has been some reports. I've just forgotten the study name or the author, but as to how that went for them, because I think that would be really useful as well. If that would uncover, I think, a few more barriers that we could try and work on. for sure. Yeah. If people are, I know some people are clinicians and treating, I'd be interested. Like I said, I'm not treating patients anymore, as to like how you feel patients feel about notifying, and when you have those discussions with them, and if, I don't know, if people are reluctant or they're keen, or, you know, I can read the research study, but it's always good hearing from people talking to patients.
Yeah, absolutely. We've got a few questions filtering into the chat, Steph, so I might read this one out. So just on the partner notification, do you think that there is a space to promote that in the health promotion space with prevention condom promoting space, or leave that for clinicians who are doing the testing and delivering results?
Oh, I mean, definitely, I think it's part of broader health promotion. Yeah, I think we all know how busy, you know, clinicians are, but particularly GPs, and you know, they're already doing so much. So anything to sort of like aid that, and this is sort of part of my broader PhD, is how we can strengthen that overall management. So even outside of the consultation room. But I think it is part of that health promotion messaging. It's just that the question is, where are people, particularly young people, where are they seeing, where do they get their health promotion messaging from? Is, I think, the question. Like, where, you know, it's probably like social media, and, you know, whether it's advertise. I know there's some really interesting sexual health promotion campaigns coming about, you know, from the health federal health department and state health departments that are great. So I think part of that, you know, messaging about looking after, just that it's part of the whole overall, not just taking your antibiotics, but part of that as well. Because if your partners aren't getting treated, you're just going to have sex again and get the infection. Many things like chlamydia, gonorrhea, you can have it cured, but then you can get reinfected. So yeah, I think that'd be really useful and important.
Just another one here. Hi, Steph. Thanks for your very interesting talk. Can I ask what social media was used to recruit participants in your study? That's from Sarah.
I think I think it was mostly Facebook, like targeted Facebook advertisements. I think that the broader, I didn't do them myself. The broader project team, I think, was involved in the social media advertising. But I think there probably is more information in the paper that I've published, or there's lots of other papers that come out about the sex, drugs and rock and roll survey that have been published. So if you have a look at one of them, I think one will provide more information about the recruitment methods. But I think it was targeted Facebook ads.
Beautiful. Yeah. Nice to see the survey backing up what we see with communication method preference for partner relationship type. So
that's good.
That's a good one
to know.
Yeah. And our search director, Jane Tomney, there are lots of studies which actually measure PN rates. Also, most partners were grateful to be notified. Yeah.
Oh, great. Thanks, Jane. Yeah, I'm sure, Jane, you've been involved in lots of that research as well. Thank you. Yes, there's definitely a lot more research out there. It is nice. It was nice to see the reasons and the caring, and then the reciprocity, I suppose, as well. So it's nice to know about the people feeling grateful as well.
Absolutely. If anyone else has got any more questions, please feel free to jump in. I'll just check if there's any more in the chat that I haven't got to. Do you have any, what does the evidence say about how effective the partner-delivered partner treatment is in reducing reinfection rates compared to like standard partner notification methods?
That's a good question. I don't know off the top of my head. I'm sorry. If someone else does, please chime in. I know it has been shown to reduce reinfection, but I don't know the rates off the top of my head. I'm sorry.
No, fair enough.
I could jump in a little bit if you like here. It's Jane Tomney. There's data overseas that shows that certainly it does significantly reduce reinfection rates, and also treats partners that may have gone untreated. There's no data available yet in Australia. We've only been doing this for a short period of time, and PDPT is used very, very sparsely. You know, there's very few GPs who actually use it. And so those data, as much as there are still some studies that we're working to collect it, there's nothing yet that's really shows its effectiveness in Australia at this point. And it's different in all jurisdictions in each of the states. Excuse my croaky voice, sorry.
Thanks, Jane.
We've got one from Jackie Fuller. With the upcoming social media bans for young people under 16, this will get increasingly difficult to promote health promotion messages on social media. Have you connected with secondary schools at all, or anyone online used these methods? It's a really good point, isn't it?
Yeah, that's
bans
a
will
great
be
point.
in a month or two.
Yeah, and it'll be so interesting to see how effective that social media.
Yeah,
because I know there's a lot of conjecture about how that will actually be enforced. We know some young people are very creative and resourceful as well. So,
getting around
but
it.
yeah, that's a really good point. 16, I guess it's 16 and younger, so it'll still be reaching a lot of young people like over 16 in the risk group. But yeah, I mean, that's what I think as well. I'm not, I don't have much of a background in like health promotion like that, just sort of broad principles. But I think you're right there, Jackie, with like that's when we'll need to engage more with schools and parents, talking to parents and providing parents, carers, guardians, as well as teachers with resources. And often it does come back to sexual health education and curriculum at schools where this can be built in. I personally haven't connected with any secondary schools, but I think it's certainly something worthwhile to look at. Yeah.
Some old school methods might come back again.
Yeah, I think like, I don't know. I mean, I don't, unless like AI we can build in something. I'm not sure. Maybe we ask AI how to do it. I'm not sure. Yeah, that I just keep coming back to, and the same with I went to the Adelaide Australasian Sexual Health and Reproductive Conference in September in Adelaide, and there were a few presentations on about schools and parents and that kind of how we reach young people that way. But again, I'm not an expert in it, so there's probably other stuff I'm missing.
That's a good point. Were there any respondents or other evidence about actual risk or posting screenshots of DMs or text messages from partners, DV risk, slut shaming, etc.?
Not that I saw in the survey that that didn't come about or was asked about. Risk of postings. Do you mean if someone sent them that? I guess it would have to be a direct message, so the notifier's identity would be known, and maybe if they've texted someone and said, "Hey, I've got," you might have been exposed to chlamydia, and if someone's sharing that, it's a good point. I hadn't considered that, but definitely would be a barrier. I'm sure a lot of young people are aware of, and definitely could be explored. Yeah. I think if there were risk of that or any concerns, or if the patient were concerned about that, and I think that's why it's important to have that discussion with the patient, that's where the provider initiated partner notification would be the better option. Or a complex situation. Yes, the public health unit. Yeah, so just to be aware, it doesn't have to be the patient, and the better option is that it's someone else than no one else. Yeah. And you feel free to email me. I've got my email addresses on the website. I'm very happy for the slides to be shared. Yeah.
Beautiful. There's a couple of questions about sharing the slides. So yeah, that's great. Thank you for that, Steph. I'll give everyone another minute or two in case there's any other questions that you want to filter through, but thanks for your presentation today, Steph.
No worries.
Here we go. Steph, I'm a secondary school nurse in a rural area. Students generally don't use Facebook. TikTok and Snapchat is the medium.
I didn't say they use TikTok and Snapchat.
Yeah, Facebook's for the mums these days.
I will feed that back actually to the Sex, Drugs and Rock and Roll Survey Project team for sure. TikTok and Snapchat. Yeah, that's so true. I'm so out of touch myself.
Yeah.
That's really good to use. And I mean, I'd love to hear, Leonie, secondary school nurse, how you think maybe partner notification messages could be, what would be the best way? Do you think it's social media, or is there something else? Sorry to put you on the spot. You can put it in the chat.
No, that's fine. I think embarrassment, like some of that stuff that is very on point, and confidence. You're assuming a level of confidence with a lot of kids, and I just find that that's not there. They don't operate from that base of confidence, a lot of them. Maybe just the socio-economic case mix that I work amongst, and also lack of resources and stuff that's in regional areas. So that's a challenge. So yeah, I could have a lot of a chat to you at a later stage, Steph. I'll look at your email, and you can have a little, I don't want to bore everyone else with the ins and outs of it, but there's a lot of great information. And I'm sorry I was a bit late. That's why I said it is the slides, because I love your presentation, because I'm doing sexual health at the moment with the with the 8s and 9s year levels. So very pertinent at the moment.
Oh, great. I'm glad to hear. I'm glad it's useful. Yeah, I think even like I didn't even know those anonymous notification websites weren't really available until I started looking into it. So even just, I think, showing young people that those things are available is so easy to use. Everyone has a mobile and a number now. Like,
yeah, exactly. And that's so I do promote that in the part in the presentation. But obviously there's a lot more limitations of that stuff up here. So anyway.
Yeah. No, thanks, Leonie. Very happy to chat more.
And probably the school nurses across the board are probably a good avenue for further discussion around that stuff if you are looking for further collection areas.
Yeah, for sure. Yeah. Thank you.
Fantastic. Well, I think we all got a lot out of that session, Steph. Thank you so much. If there's no more questions, I'm happy to wrap up a few minutes early today. So I'll give everyone another minute or so to jump in. But yeah, thanks so much for your time, Steph. We got a lot out of it. It was really interesting. Good luck with the rest of your PhD.
Thank you. Thanks, everyone.